Hi, thank you very much for having me today to discuss this. I have no conflicts of interest. So fenestrated endovascular aneurysm repair is something that's increasingly being used, becoming more widespread. Overall, still, I think we're pretty early in the data collection phase compared to a lot of other procedures out there that have a lot more longevity and that are a lot more spread out in among different places. So the conservative data that's out there is how generalizable is this data? What are the follow-up options? And is there a way to really make these compare to open AAA repair, which in modern hands is used a lot less than historically? Common US databases we use to track procedures include National Inpatient Sample. This has the least amount of granular detail. It does have cost data though, which a lot of other data sets don't, except for Medicare. And it does have limited 30-day outcomes. The National Surgical Quality Improvement Program has targeted data sets and 30-day outcomes as well. However, it's not very granular as well, with procedures mostly being confined to CPT codes. Then there's also the Vascular Quality Initiative, which we'll talk about a little more, which has the most granular data and which has long-term follow-up as well. The Vascular Quality Initiative initially began in 2003 as a vascular study group in northern New England, comprising of Maine, Vermont, New Hampshire. Started at 6 hospitals that started with carotid, AAA, and infrarenal bypass registries. Over time, this expanded to all 6 states of New England, became the Vascular Study Group of New England, and then eventually expanded and became the National VQI, containing over 600 hospitals. They expanded in 2011 initially, different regions. You see all the regional groups here too, and it's international with a Canadian group as well. We'd love to have a Chilean regional group as well. Overall, there have been over almost 300 publications, over 600 centers, and over 700 procedures captured in the VQI. The challenges, it does cost money to put this data in. So you're going to do a procedure, you're going to put in all the patient demographics, all their comorbidities, you're going to put in the details of the procedure as far as what you did, what devices you put in, what stents you used as adjuncts, and you're going to have follow-up of this as well. So the patient's going to come back at 1 month, 6 months, and a year, and you're going to have follow-up on this patient that hopefully you'll follow for the rest of their life with this. And someone has to really coordinate a lot of this and report it. Oftentimes the physicians themselves will enter the procedure data, but data coordinators needed to enter a lot of the patient demographics, comorbidities, and follow-up data. So who's actually recording the data? Is the attending? Is it the fellow? And who does the follow-up? This is very important, and there's a challenge to this, because often this is handled on the local center level. There's also a risk of underreporting, or cases missed, or additional procedures missed. If a patient goes to another hospital in town or another area in the country, is there a chance they're having interventions that we don't know about that we're not capturing? Also, are you missing complications that happen? If a right renal limb went down and they went to the hospital, would this be missed? Or if it was asymptomatic, would be missed if they lost the follow-up? Sometimes there are still empty fields that are not filled out that oftentimes can make the data not complete. Also, this difference of judgments and follow-up is not as, you don't have a, for NISQIP, you have a standardized nurse abstractor who's trained that has specific definitions where it's really based on the center and the Vascular Initiative. So is this a real endoleak or not? Is that really a stenosis in the limb? So things that come up that may be different interpretations. Also unclear, and so maybe some issues with clarity in the registry as well. In the standard EVAR registry, you may have a small AAA that gets recorded, but doesn't really appreciate that there's iliac aneurysm being treated at the same time too. So there are issues where you may not completely capture what's going on and why the intervention happened, or maybe there's a difference in size over time that wasn't appreciated, and it grew in 6 months. Overall, the VQI does allow more granular preoperative and intraoperative data. It does allow follow-up. It can be linked in the US to Social Security Death Index for mortality, so you can have a better accurate view of mortality for people, which is probably one of the more accurate factors in the data set is the survival. You're not constrained by ICD-9, ICD-10 code, and CPT codes, which a lot of other data sets are, where you just look at a CPT code and have to go based off that and not have the granular detail. The barriers. There's no cost data here as an issue. Follow-up data is always an issue. Getting people to follow up. The first 2 EVARs I did as an attending, I never saw the patients again. And really, some EVAR, you have to follow these people. The quality is also just as good as the data enterer. So poor data entry is poor quality data. And there can be a lot of variability for that at the local level. What's unique in the VQI that data sets don't have? You have details of day of the week, smoking cessation timing, details about congestive heart failure and other medical conditions, so you know how severe it is rather than they have CHF or not. Medication details, but not dosing. If they're on a statin, an ACE, an ARB, aspirin, Plavix, or beta blocker. For the EVAR, TVAR, FEVAR databases, you get access type. Was this a cut down? Was it perk? Was one side cut down? Was one side perk? Was it pre-closed with per-closed devices? Was there a failed access that required a cut down? Graph sizes, the details are included, configuration and branch details as well, concomitant procedure details as well, if other adjuncts were done, and also complication details as well that are specific to the procedure. Imaging follow-up and reintervention is also is that present as well, which would be missing on a lot of other registries. For the open AAA for comparison, you get clamp details, you get concomitant procedures, you get ICU details, MI details, and interventions as well. If you want to compare complex open AAA to FEVAR. I said the follow-up is one of the most challenging things. Sometimes it's hard to track people down. People move, people come in and out of the country, people just are overwhelmed with seeing other physicians that don't follow up. People may be in the hospital, miss their appointment, they're reschedule it. These are always things you have to deal with. Things may have follow-up, may not be recorded, they may go somewhere else. You may miss reinterventions. The VQI has recently started to link to Medicare data, which for Medicare patients could help solve this problem to an extent. So you can see follow-up imaging and interventions that they may have had done, and also better follow survival. Paper that Dr. Simons is an author on, who's been on the panel today, looking at determinants of follow-up failure in people undergoing vascular procedures. This is a very common problem that we have. Rates of loss of follow-up were center specific. Some had all the other patients followed up well, and some had a low amount. Loss of follow-up was associated with people who had previous PCI, open AAA, discharged to rehab as well, surprisingly. There's also the U.S. Fenestrated Branch Consortium that Dr. Simons Center is part of. These are 9 centers with physicians that have IDEs to treat thoracoabdominal devices with Cook. These are specific FEVAR, BEVAR devices and off-the-shelf devices. And I've been involved in this when I was training as well. The things that they've examined through this have been sex-related outcomes, outcomes of octogenarians, spinal cord ischemia, reinterventions. The strength of this is that you have expert participants here, so you're going to get the best of the best doing the procedures here. You're going to have granular follow-up, specific detailed follow-up. These are people that really have organized centers of aortic excellence that follow their patients long term and are dedicated to it. So your follow-up is going to be much better here. It's going to be much more granular, and oftentimes the patients are going to come back to where they came from here for these. Weaknesses, though, is one is broad applicability. So you may have great data from these 9 people, but does this go everywhere? If you want to see how an average patient in the average place would do with a FEVAR, is this not applicable to how the average surgeon would do when you have a non-expert? You may have fewer similar open AAAs in the same centers for comparison because it's so aggressive of doing endovascular procedures for accurate comparison. So conclusion, registry data is essential for new technologies such as FEVAR. It's necessary to compare to historical operations. One thing to consider with comparison to open AAA is that you may not have the best AAA outcomes that you did compared to 20 years ago, since we're not doing them as much for open complex AAA. And long-term follow-up is critical to any of these data sets. That's the biggest barrier probably to these data sets. And also you need to assess board applicability outside of expert hands. Thank you.